honored to be a part of this wonderful series, and thank you so much for having me. The title of my presentation today is Diagnosis and Management of White Spot Lesions in Orthodontics. As usual, even though this is a virtual presentation and you all did an amazing job in introducing me, I always dedicate a few slides to introduce myself further so you have an idea where I grew up, who I am. I grew up in Istanbul. This is actually the neighborhood where I grew up. Our mother would bring me and my two brothers to the park right behind that mosque. And Istanbul sits on a body of water, which is the Bosphorus. And that water basically splits the city into two continents, Europe and Asia. I grew up on the European side. And Istanbul is a very cultural city. You can find all kinds of historical buildings, and this is Saint Sophia or Hagia Sophia. We have churches with beautiful mosaics. So it's a big city with a lot of culture and population. Our unofficial number is 17 million, but the official number is 13 million. And this is a view of the bridge that connects Asia to Europe. And this is where I grew up. And then I came to the States, and right now, I actually live in Richmond, Virginia, which is here on the red state right there on the right side, on the East Coast. Richmond is in the middle of the state. So there's land all around me. And, but Richmond is a neat city because if you go 2 hours north, you go to Washington, D.C., 2 hours west is mountains, and 2 hours east is the beaches, Virginia Beach being very popular tourism location. Here's a view from the city, Richmond, and we have James River. Even though it's not a sea, still we'll take it. So as you can see, during the hot and humid summer days, Richmonders go to those to the banks of James River to get some fresh air and to cool off. Okay, now back to my talk. What are the objectives of my talk today? First, I will briefly discuss the causes of white spot lesions. Then I will review a study that looked at the perceived responsibility for the development of white spot lesions. Then I will discuss the treatment modalities that are used by both general practitioners and orthodontists. Then I will concentrate on some products and techniques with efforts to prevent white spot lesions from forming. Then I will switch gears and I'll talk post formation, like once the lesions form, what can we do? After they formed, is there anything we can do to improve the aesthetics? That's what I will review. And I will conclude my talk with a summary. So my talk today is basically based on evidence. In order to do that, I did either literature review, some systematic reviews, or actual randomized clinical trials. I will also report the results of my own research that I conducted here in the US. And at this time, since I will be mentioning product names, I want to make sure that I disclose I have no relevant financial or non-financial relationships in any of the products or services that I will discuss today. I'm simply bringing out there what I know, what I learned, and share it with you so that we can maybe use it to help our patients to either maintain a good oral hygiene or to minimize the formation of white spot lesions. This is a question that I get sometimes. I'm not sure how it is in India, but in the US, there are some patients and parents think that braces actually cause white spot on teeth. Of course, we clinicians, we know that no, fixed appliances do not cause white spots on teeth. However, we're also aware that in the presence of fixed appliances, the O-rings, power chain, or ligature ties, it is more difficult for our patients to brush and floss efficiently. And if there's a prolonged plaque retention, unfortunately, we may end up in some cases like shown in these pictures. This is very unfortunate. So indeed, when there's a prolonged plaque retention, enamel demineralization will be initiated or it will progress due to poor oral hygiene. And in the literature, this is well documented that once we bond the brackets, even the patients with good oral hygiene, in those patients, there is an increased level of acidogenic bacteria, and these bacteria are responsible for the development of the caries, or in our case, white spot lesions. So at the critical pH, basically the calcium and phosphate ions will be released from enamel, and this is around 4.5. And then this process is called demineralization. However, saliva has a buffering action. So saliva can bring the pH to the normal levels, which is around 7. And if there are available calcium and phosphate and fluoride ions in the medium, these ions may be incorporated back into the enamel, and in that case, the remineralization can be initiated. So in an oral environment, especially in an orthodontic patient population, there is a tug of war that is going all the time. It can go to the left where there's bacteria and carbohydrates, to the right where is calcium, phosphate, and fluoride. So this equilibrium can shift back and forth, left and right, left and right. However, if it is shifted to the left, and if the duration is longer, then the demineralization may be initiated, and it may, if it is consistently in this left side, then basically demineralization can progress, and it may never go back to the remineralization. That is why it is extremely important for us orthodontists to identify these patients at risk at the beginning of the orthodontic treatment, and to do everything to our power to prevent the equilibrium to shift to the left. If you look at prevalence studies or some incidence studies, the numbers range from anywhere 2% to 96%. If you look at those studies, the main reason why we have such a wide range is basically due to the differences in the duration of the study design, the detection methods, or the study design itself. So that's why we have quite a wide range. In 2011, we conducted a study at VCU, and in this study, we chose our patients with ideal oral hygiene with no white spot lesions, and we observed these patients in 6 months and at 12 months. What we noticed that 38% of patients at 6 months had at least one white spot lesion. And the number went up to 46% at 12 months, and after that, it kind of leveled off. So this is very actually in agreement with a study that is well known, and it is cited in every white spot lesion study or publication, which is from the group Gorlick et al. That was published in 1982. According to Gorlick, about 50% of our patients will develop at least one lesion during their orthodontic treatment. So I think it is a fair number to say that at least half of our patients will have some kind of white spot lesions. So what are the risk factors? Of course, poor oral hygiene is one of the main reasons. And also the diet. Is the patient drinking constantly sugary sodas or eating all those carbohydrate-rich snacks? And then history of carious lesions or high DMFS index. So some patients by genetics, they are predisposed to white spot lesions. And if we don't do any additional methods to help our patients to prevent these lesions from forming, yes, these patients will be at risk. And orthodontic treatment time is also related to the incidence. So white spots, it's our problem. It's a challenge. We deal with it almost on a regular basis, unfortunately. So can we do anything? And when I say we, I included patient, orthodontist, and dentist. So of course we can do something. One of the best defense against white spot lesions is good oral hygiene. And if our patients, they use even over-the-counter fluoride toothpaste and fluoride mouth rinse, if they do what they're supposed to do, it is effective and we can minimize the formation of these lesions. However, the biggest problem that we're running into is the compliance. This is when we're like, okay, what can we do? These patients, no matter how many times we tell them to brush and floss, they're not doing it. And speaking of compliance, here's my daughter. And as you can see, this is a perfect picture of being non-compliant. Now she's 25 years old and she goes to medical school, so she became a good girl, but compliance is an issue. So as you mentioned earlier, I did a Master of Science in Health Administration, and one of the concepts that I learned was economics. And fourth principle of economics is basically people respond to incentives. So these can be positive and negative incentives. And there's a reason I mentioned this. In the US, almost any private practice will have some rewards programs. So it is such a big problem and it is such a concern for us orthodontists that we are trying to do anything to encourage these patients to brush, to take good care of their teeth. So what is rewards programs? If you go back to your appointment, your adjustment appointment, and you have good oral hygiene, no broken appliances, then you get to collect those little coupons or tickets. And when you accumulate a certain amount, then you can basically turn those in, get a prize. And believe me, there are some orthodontists who give away iPads or gift cards from the stores. So this is positive incentive. Of course, at VCU, we don't do that. At VCU, we do the negative incentive, which is actually called Book of Shame. So Book of Shame is filled with nasty teeth. We have those patients who at the end of their treatment might have good occlusion, but who have caries. Or we have some really bad cases that we collected from other friends and colleagues. So we have this book which we show this to our patients and keep telling them, if you don't brush, if you don't floss, if you don't use your mouth rinse, these may happen. And another thing that is very common these days is now we are in digital technology. Look at us. I am connected to you, to India from Richmond, Virginia. So technology plays a big role in education as well. There are now systems, some programs, applications that send reminders to the patients to remind them to brush their teeth, or if they brush their teeth already. And if you look at the studies, the effectiveness of reminder, text message reminder systems, it shows that actually If patients receive reminders on a regular basis, their oral hygiene is improved. So it looks like reminder systems work. But no matter what, how many times we gave a pep talk to our patient, we did a demo, how to keep their teeth clean, we will have some cases like this one. Very nice occlusion. Obviously, orthodontic treatment was completed. However, every single tooth has white spot lesion. And when you finish a case like this, the very first thing that we all, I'm sure, experienced at some time in the past is, why do I have these? The minute you debond the brackets and these white spot lesions are so visible that patients all of a sudden are so shockingly surprised. And the presence of these lesions may lead to patient dissatisfaction. In some cases, unfortunately, we may need to refer our patients to general dentists for cosmetic intervention. Okay, so I will go over some systematic reviews. This is from 2015 and 2013. This review was on a general population. And this is showing us the evidence that especially tooth files and mouth rinse, which are easy to do. If there's compliance, they work. If there's no compliance, and then fluoride gels and fluoride varnishes, they work as well. But as I mentioned, this systematic review was on a general population, not specifically orthodontic patient population. So who is responsible, even though we have this shown method or effective product, these still are forming, and we're still witnessing demineralization. Who is responsible? Well, this is what we wanted to figure out. This is a survey study that we conducted at VCU. And the purpose of this survey study was to assess the perceptions and level of awareness of patients, parents, orthodontists, and general dentists toward the development of white spot lesions during orthodontic treatment. So we asked all those groups a series of questions. I only included here the most important questions. One of them was, once the teeth are straightened with braces, how much do white spots make the teeth look worse? And in this case, we only allowed the respondents to circle one answer. And if you can look at the third row, which is orthodontist, 60% of orthodontists thought that formation of white spot lesions make the look a lot worse. So it is, and this was statistically significant than the other groups, the orthodontic group. So it is obvious that we orthodontists take this seriously and do everything to our power, but still that happens. Then the next interesting question, which was actually the fun question, who do you think is most responsible for the prevention of white spots from braces? So in this case, thankfully, 87% of patients thought that they are responsible for the prevention. Both parents and orthodontists, 77% and 78%, they thought that patients were responsible. However, if you look at general dentist answers, only 66% of general dentists thought that patients were responsible. They thought that both parents and orthodontists were equally responsible. I think this is important because it puts us on the spot, being a clinician and being basically responsible for the prevention. We need to do something more than we do actually. Now I will switch to another study, which was also a survey study. In this case, we surveyed general dentists and orthodontists, and we asked a bunch of questions that asked the practitioners what kind of prevention method they would be using. And if you look at this table, This was recommendations for use of fluoride by patients who have severe white spot lesions. About 70% of general dentists and 76% orthodontists, they indicated that they would, or they are, immediately prescribing white spot lesions. Only a very small proportion of these clinicians are waiting a few months after debonding. And this is a very important point that we will discuss later in my lecture. And here is a list of various methods or materials that we can use. And here, what we did, we also divided the clinicians into groups of based on their experience. So there is a product which is MIPACE with Recaldent. That's the commercial name. And we will discuss this product later in detail. It was interesting to see that this product is quite new, maybe within the last decade we had this product. So it's interesting that only clinicians in both groups, general dentists and orthodontists, if they were in practice up to 10 years, they were recommending this product. So I think being familiar what is available out there is also a factor. And as far as the same question, waiting a few months to allow saliva to remineralize white spot lesions, that question, none of the general dentists were waiting, but at least some proportion of orthodontists were waiting a few months to allow the saliva to remineralize white spot lesions. And once again, we will talk about these concepts later. In 2005, so the systematic review that I gave you was for general population. It was more recent, but I wanted to include Benson and his group because they did a series of systematic reviews. Their very first systematic review was in 2005, and this was specifically orthodontic patient population. And based on this review, at the time, the authors recommended that rinsing with a 0.05% sodium fluoride mouth rinse was effective. There was some evidence for its efficacy. Also, glass ionomer cements used for bonding were found to reduce both the incidence and severity of white spot compared with a composite resin. In 2010, Rogers et al. Conducted a study, and this study looked at the efficacy of glass ionomer cements in preventing demineralization. And these authors reported that there was some evidence that glass ionomer cements will reduce the formation of white spot lesions. However, even though in their study they did not directly measure the bond strength of glass ionomer cements, they went on and they made this statement: because of the limitations of successful bonding with a glass ionomer adhesive, it cannot be recommended. This made Benson unhappy, and he wrote a commentary. And he said, I would like to question one of the author's conclusions. They stated that because of the limitations of successful bonding with a glass ionomer adhesive, it cannot be recommended. Philip Benson went on and he said the newer resin-modified glass ionomers are much stronger. And he also indicated in his commentary that at the moment, at that time in 2010, they were conducting a randomized clinical study that was looking both the efficacy of glass ionomer cements in reducing white spot lesions and the bracket failure rate. So that study was finally, the findings of that randomized clinical study was published in 2019. And according to this clinical trial, there were no evidence that the use of resin-modified glass ionomer cement has advantage over light cure composite for bond and brackets in reducing the incidence of white spot lesions, and there was no differences in bracket failure. And in detail, here is what the bracket failure rate. Even though there was no difference in incidence between those two groups, which was resin-modified glass ionomer cement and conventional composite, the authors said that maybe less severe lesions, but the statement was not a strong statement. It was maybe less severe. So as far as bracket failure, if you look at the numbers, actually resin-modified glass ionomer cement had 6.4 versus conventional resin 7.3. In a typical orthodontic clinic practice, 3 to 4%, up to 4% is the routine expected failure rate. So both of these cements basically had more than expected. The authors finally concluded their paper that we should consider using resin-modified glass ionomer cement for banding. I think there's a reason for that. If the bands become loose, plaque can accumulate on the tooth, and probably because of the fluoride release and reuptake, using these cements would be effective for banding the bands. In 2013, the same group, now they did a review to their 2005 review. So in this case, they added one more evidence. They reported that there was moderate evidence that if we use fluoride varnishes every 6 to 8 weeks, then there is a 70% decrease in white spot lesion formation. However, once again, the application was more often than the typical fluoride varnish use, which is in pediatric dentistry every 6 months or twice a year. Then to this 2013 review, in 2019, they did another update. And according to this very recent update, the authors concluded that there is a low level of certainty for fluoride foam applied professionally every 6 to 8 weeks in minimizing or reducing the proportion of orthodontic patients with lesions, and also low level of certainty that high fluoride toothpaste has an effect in minimizing lesions. So this is what we have based on systematic reviews up till 2019. But then there are, if you look at the literature, there are a lot of reviews, systematic reviews, or randomized trial, or commentary based on randomized trial. So if you read all of these, you get all kind of information. So at least what I gathered from these is that, yes, there is at least some evidence with the use of mouth rinse, with the use of gel, with the use of varnish. So there is some evidence. And I think it is better than doing nothing, but there is not that strong evidence that we're desperately looking for. As far as MI-PACE, which I included in that survey study, and that was one of the questions, MI-PACE is actually a casein phosphopeptide amorphous calcium phosphate. In the US, it is MI-PACE. In Europe, it is marketed as Tooth Mousse, and the Tooth Mousse Plus is the one that has fluoride in addition to CPP-ACP. And when you look at the efficacy of this product in preventing lesions, it is all over the place. There is one study indicating that there is no significant effect. Then there's another study showing that the lesions were less deep. And then there is another systematic review from 2018 that reported really conflicting results. They started with 123 studies. They narrowed it down to about 13 or 12. And there was a few, like 3, showing that yes, it's effective in minimizing lesions. Then there was another 4 showing that no, it's not. So I think it's fair to say that we don't know yet. There are very conflicting results with the use of CPP-ACP. How about sealants? Because now we have sealants. One of them is Opal Seal. Currently, the companies market their products that the new generation sealants are better than the first generation sealants, because now the sealants are filled. And because they have those fillers, they are filled with resin, then the material is stronger and they are not vulnerable to attrition and abrasion. And because they stay on the surface, they provide continuous surface coverage. So the retention of the product is improved, and all we need to protect the enamel is to have a continuous surface coverage. So this is what is the marketing with the new sealants. And one of those sealants, as I mentioned, is Opal Seal. This study was about 10 years ago. And at the time, this product was just introduced to the market in the US. And left and right, I was receiving phone calls from private practitioners asking about this product, because the rep of this company went and gave them some lectures, and they were asking me about the evidence. And when I did my own search, I found only one study, 24-hour study, that was conducted at the manufacturer's lab. And this product is marketed by Ultradent, located in Utah. There was only one study, 24-hour study, which looked at the fluoride release and fluoride reuptake. And based on that 24-hour study, the company was making all those claims that it prevents demineralization. So this is what prompted me and Daniel Penola. Dr. Penola was one of my residents. We wanted to conduct a clinical study. And here is the website of Opal Seal. In this clinical study, what we wanted to do was to recruit patients, healthy patients with no white spot lesions already on their teeth. And if these patients were scheduled to have their premolars extracted for orthodontic treatment purposes, we tried to recruit these patients. And it was a split mouth study. So if one premolar received the experimental product, which is Opal Seal, which is again fluoride releasing product, the other premolar received just the conventional primer that doesn't have any fluoride in it, that doesn't have any efficacy in preventing white spot lesions. And this is exactly what we did. We put a separator on that tooth. Due to the ethical purposes, we were not able to tell our patients not to brush and floss, so they had to carry their usual oral hygiene. But we ask our patients specifically to schedule their extractions at the end of 90 days, after 90 days. Or around 90 days. And this was something that we couldn't control well, because most of our patients wanted to go back to their dentist to have their teeth extracted. So we couldn't play a role in scheduling those extractions. So our patients basically were asked to go and brush and floss as they do. And when they brought us those teeth extracted, then we had our samples. Finally, what we did, when those teeth came back to us, what we did first was to use a visual examination technique that was used by Gorlick et al. And this is something that you visually examine tooth surface. So two calibrated clinicians looked at the tooth surfaces without knowing which tooth received which treatment. And we rated them: no lesion, slight lesion, visible lesion, severe lesion, or cavitation. So incidence rate was very interesting. As I mentioned, we didn't control the duration of the treatment, despite the fact that we aim for 90 days. We had some patients who had their teeth extracted at 41 days, and we had some patients who had their teeth extracted at 143rd, 45th day. So there was a wide range. And when we were analyzing our data, what we noticed, there was some interesting dynamics going on around day 90. If the teeth were in the oral environment less than 90 days, teeth in the sealant group had only 29% white spot lesions, as opposed to teeth in the control group that had 46%. So this was statistically significant. So we were able to see some effect if the teeth were in the mouth less than 90 days. However, there was no significant difference in incidence of white spot lesions between these two groups over the course of the study. Since visual examination is somewhat a subjective method, we also did microhardness test. As we all know, sound, healthy enamel has a hardness that is above 300, it's about 310. Of course, this will depend from person to person, but what we did, we chose indentation sites away from the bracket towards the gingival, also deeper towards the dentin. So you would expect that under the bracket, you shouldn't see any effect because that area is covered with the bracket. What we noticed that there was a significant change in hardness difference across the 6 depths of the enamel surface. And we also saw that the hardness was even lower than the other areas. If you look at the 25 micron and 50 micron depth, then the enamel was back to its actual hardness values. I think this is very important. So basically during the etching process, we are making the enamel soft, and we definitely need to cover the area that if we etch the whole tooth surface, it is wise to apply a sealant. Otherwise, we're already predisposing the tooth enamel to demineralization. We also looked at the primary retention, something that is claimed by the companies that this product is better than the first generation sealants. So at 90 days, the values that we saw were around 50%, and we couldn't find any correlation between the percentage of the experimental product remaining on the buccal surface of the tooth and how long the tooth was in the mouth. And we did this calculation based on quadrant system. We basically visually tried to add up the quadrants and to see if it is 25%, 50%, 75%, or 100%. And in our study, we found that at the end of 3 months, there was only 50% of the product still remaining. So we can say that the protective effect of opal seal seems to exist up to 90 days. And maybe this can be explained with 2 things. Either because the sealant is not there at the end of 90 days, because we have only 50%, that's why we had a diminished effect after 90 days, or the fluoride was releasing from the product. And we know that the fluoride release from these materials, there will be an initial burst, then the fluoride will be diminished over time. And even though reuptake is mentioned a lot, maybe fluoride reuptake does not occur, especially in patients. If the patients are not brushing with toothpaste, and if they're not incorporating any fluoride to their oral cavity, maybe there is no fluoride for the reuptake to take place. So again, why the effectiveness is lost after 3 months is questionable, and it could be related to those 2 points. In 2015, a German group conducted a similar study, but their study was an in vivo assessment under black light. Once again, I think I forgot to mention that opal seal has a fluorescent agent in its composition. In a dark room under the black light, you will be able to see if it's there or not, because it's gonna fluoresce. And it is shown in this picture on the upper right. So this is what exactly these authors did, and they did the similar way. They basically divided the tooth surface into quadrants, and they said completely preserved, more than 50% preserved, less than 50% preserved, or no sealant preserved. And they reported that surface coverage after 100 days was about 50%. And they concluded one single application is unlikely to last. Therefore, the authors recommended multiple application, reapplication every 3 months in order to have a protective effect of opal seal. This is what brought me to a few studies that I conducted, this time with the University of Oklahoma. I was lucky enough to be involved in these clinical studies. So 2 residents, Dr. Booth and Dr. Holt, they did the first part of this clinical trial. The purpose of our study was to evaluate the longevity of a fluoride-releasing orthodontic primer sealant at 3, 6, 9, and 12 months. And here is the diagram showing our patients. We were able to recruit 148 patients. These patients were healthy patients with no white spot lesions, and they were randomly divided into either opal seal experimental group or to the control group. And control group, once again, received a product that didn't have any preventive effect. And the patients in the opal seal group this time was divided into 2, once again randomly. One group of patients had only one-time application, and they were observed afterwards. The other group had repeated applications. Oral hygiene at baseline, which was at T0, bonding appointment, was checked. We made sure that they were all eligible. They were patients with good oral hygiene, no white spot lesions. Plaque index and gingival index, these indices were also measured at 6 and 9 months. We assessed these patients every 90 days. At least I should say, once again, we made an attempt to assess these patients every 90 days, which wasn't the case. Unfortunately, it ended up being every 120 days. Once again, in an educational institution, very busy practice, it is hard to follow, closely monitor these patients. So we weren't good in controlling that. But our time points were T0, which was bonding appointment, T1, 3 months, T2, 6 months, T3, 9 months, and T4, 12 months. In addition, what we considered was the age of the patient, whether the patient was female versus male, because we think that females are more compliant than the male patients, especially children. Whether the patient was left-handed versus right-handed, and then whether they lived in a place, in a house at a city water or well water. And also we noted whether the orthodontic treatment included extractions versus non-extractions. And their beverage of choice was also another factor, whether these patients drank mostly water or they drank mostly those sugary sodas. Pre-bonding photographs were taken. We dedicated a room. We set this room for photo taking, and therefore all of the photos, pre-bonding and post-bonding, were taken under the same conditions. Standardized photos were taken. And we took photos also in a dark room. The control group, as you can see, has nothing shining because control product doesn't have any fluorescent agent, as opposed to on the right, you see the sealant. And in this case, if you look, you will see shiny surfaces, shiny areas. That means that the primer, the sealant, because opal seal is used both as a primer and sealant. So this product, if there's a shiny surface under the black light, then there is product on the tooth surface. What we did in this study was very unique. This was a great improvement from my own study that subjectively looked at the surface and kind of approximated the retention of the product. In this Oklahoma study, what we did, we had a custom written software. We were able to choose an area of interest, and then the software could go and look at that surface and differentiate the dark pixel, which represented enamel, from the bright pixel, which represented sealant. And it was able to make all those algorithms to give us a definitive calculated number. Here are the results of our study, and this is, we did the study only on the maxillary 3-3, canine to canine, and the graph and the table are represented here. I think it's easier to follow on the graph. At T0, which is the bonding appointment, the overall percentage, surface coverage was only 80%. So this was the beginning. Even at the beginning, we didn't have 100%. So maybe applying this product is somewhat technique sensitive and it requires some extra attention. So we started at 80%, but at T1, which is 3 months, we went down to 58%. At 6 months, we went further down. The percentage was only 56%. At 9 months, we saw that the surface coverage was about 52%. And at 12 months, it was about 51%. So there was a sharp decrease. That infamous 3 months, here we go again, there was a sharp decrease within the first 3 months. Now I am giving you the results of one-time application and multiple application. So in this case, product was reapplied we aim for 3 months, but this study we were able to do every 4 months, as I mentioned earlier. So if you look at it, at 6 months, when we reapply the product, by the way, the solid line is the one application and the dotted line is the reapplication. So if you look at it, at 6 months, yes, we were able to bring it up a little bit, but never back to where we started. Same at 9 months, we brought it a little bit up to like 58%, but never back to 80% that we had initially. So it looked like, even though we apply this product, still it doesn't go, it still wears away and it's not staying there on the tooth surface. I think if we look at the study from Germany and my study, we both found around 50%, and in this study it was 58%, and it was about 50% at 12 months. So I think these numbers are pretty much the same. There is not a drastic difference. So bottom line is this product is not staying on the tooth surface. So the conclusions of that study was there was a statistically significant reduction in surface coverage from bonding to each subsequent time points for both one-time application and reapplication groups. The question to answer at this time would be, is there a correlation between person sealant coverage and prevention? This is what we should go after. And this is indeed what we did in the second part of the study. This time, Dr. Danielle London continued to observe in these patients that were enrolled in this study. So what she did was to compare, the purpose of her study was to compare the efficacy of a highly filled orthodontic sealant with a non-fluoride containing conventional material. And the second purpose was to compare one-time application to repeated application of Opal Seal in prevention of white spot lesions. Here is the breakdown of the patients that she followed. So the assessment methods were two ways. She first basically we did visual examination. It's not only her. We had three clinicians, one orthodontist, one pedodontist, and one general dentist, all calibrated, examining the photos visually for the presence or absence of white spot lesions. She also used Diagnodent on these patients at debonding and 3-month retention. The visual examination, once again, was similar to the method recommended by Gorlick. And Diagnodent measurements were done on the tooth surface in 4 quadrants. And I don't know if you're familiar, but Diagnodent will tell you if the tooth is healthy, the reading will be between 0 to 13. If there are enamel caries, it will be between 14 and 20. Usually, the proper method is everybody has different composition. So what you do is you first calibrate your pen, your Diagnodent pen, on the healthy area of your tooth surface, and then Diagnodent, when you go around and measure those suspected lesions, it will basically use that as a reference and give you a reading. So that's what she did. And the results of her study show that there were no statistically significant differences in incidence or severity of white spot lesions between the 3 treatment groups. And she concluded that there was no added effect with sealant reapplication every 3 months. And as far as the other factors that we considered, like age, left-handedness, right-handedness, drink of choice, there were no statistically significant differences in any of those, including well water and city water. Even though well water and city water, there was no significant difference, still there was a trend that the well water patients had somewhat higher incidence of white spot lesions. So from her study, we were able to say that there was an increase in white spot lesions, incidence and severity with treatment time. And what she also noticed that when she did these readings with Diagnodent, 3 months after debonding, the numbers went down. So there was some decrease in white spot lesion incidence and severity at retention. In 2020, there was a study from Turkey, Cömert and Öz. They also did a similar clinical study, and these authors also reported that fluoride releasing primer has no significant advantage in reducing demineralization over the control primer. So that's what I have as far as primers and sealants, high-filled sealants. So now we're gonna switch to what we can do once these lesions are formed. What happens? Is there anything we can do to improve the aesthetics? What is the fate of these lesions? This is what I mentioned earlier that I was going to discuss in detail, the concept of waiting for 3 months, not prescribing a high concentration fluoride delivery system at D band. This is from Ogard, who is an expert on this area, on this field. According to Ogard, we should not prescribe high concentration fluoride. This is because if you do that, if you look at that picture on the right side of the screen, we will only help mineralize the outer surface of the lesion and the subsequent layers will not be affected. So Ogard, what he recommends is not to do anything. Leave these patients alone. Just ask them to brush with a low concentration fluoride, which is typically over-the-counter toothpaste, for about 8 weeks to 12 weeks and see what happens. This is his recommendation, and that was the reason why in our survey study we included this very important factor, because it seems like many orthodontists right away when we see those lesions, we're like, okay, go ahead and use this high concentration toothpaste. So we should not do that. And the studies that looked at what happens post-orthodontically, these lesions, they reported that about 60% remain the same. However, there is like about 30% that become less severe, like the depth could decrease or the size could decrease. So there's improvement in about 30% of these lesions. Thankfully, only 10% become larger and only about 3% will require restorations. So here is a photo that was given to me by late Dr. Samir Bishara, who was at University of Iowa. Even though he was at another university, he was a mentor to me. So I remember him respectfully. He provided these photos to me, and the top photos were taken at the debonding appointment, and the bottom ones are taken about 3 months later. So you see there's great improvement in aesthetics. Of course, maybe if these lesions were really, really superficial, there was some remineralization, or it is possible that some of the aesthetics was improved because when the patients brushed, this unhealthy soft enamel was, erased from the tooth surface. So that could be the case. But overall, it looks like it's a good thing to do, just not to do anything, at least for several weeks after debonding. When we look at the CPP-ACP for post-orthodontic application to help with remineralization of these lesions, authors from Turkey, Akın and Başçıfçı, they saw that, they reported that CPP-ACP was more beneficial than fluoride rinse for post-orthodontic remineralization. However, a 2013 meta-analysis from a group out of University of Washington indicated that there is no difference in the effectiveness of MI Paste Plus compared to standard oral hygiene. A more recent systematic review of randomized controlled trials was published, and this is a 2019. And according to this one, the authors concluded that both CPP-ACP, the regular one or the one with fluoride, can decrease the prevalence and increase the remineralization of white spot lesions during and after orthodontic treatment. However, again, based on what we have in the literature, I say that there is not a strong evidence that support this statement. I think we need more randomized clinical studies to show the evidence of this product. Another method to improve aesthetics, definitely not for remineralization purposes, is microabrasion. Repeated applications of a pumice and 18% hydrochloric acid slurry to the demineralized tooth surface has been shown to improve the aesthetics. Basically, the success depends chiefly how deep these lesions are, and also the improvement in aesthetics occurs because of the removal of white spot lesions through this method. Once again, that unhealthy discolored enamel is removed. So a 2007 study indeed showed a significant reduction in lesion size, and a 2012 study from Pliska out of Canada also did similar study with microabrasion, and they used MI paste in one group, and in the other group they only did microabrasion. Whether you use MI paste or not, they were able to show that microabrasion improved the aesthetics and reduced the size of white spot lesions. So there might be this might be a technique that we may use to improve aesthetics. Here are some photos before and after. The left side shows the lesions, and on the right side, the lesions are not that visible. Another new product that is very popular, at least in the US lately, is ICON. And ICON is acronym for Infiltration Concept. This product is marketed by DMG. It's called No Drill Fill. So it consists of etching the surface with 15% hydrochloric acid. Then you apply alcohol, and then you occlude the pores that you created with this low viscosity light curing resin. And then you finish the surface as you would with polishing discs. Here are some photos that show improvement, but in this case, what we are doing is really the healthy enamel, diffraction index of healthy sound enamel is 1.62. If we have porous lesions on tooth enamel, the diffraction index with saliva is about around 1 point. If you apply this product and you fill those pores, then diffraction index is brought back to 1.43. So basically, this is perfectly a physics. We're deceiving the eye, and we're no longer able to detect these lesions. That's what is the basis of the improvement in aesthetics. So this product, as I mentioned, is pretty new, and the stability was a question, and there are a few studies out there. And this study I was involved with was carried out at the University of Texas in Houston. So what Kevin Holgren, who was a resident there, Dr. Holgren, what he wanted to do was to look at the color properties. When you treat the tooth surfaces that had white spot lesion with this resin, what are the aesthetics? So he did a color study, and he reported that there was a significant improvement, and the color properties were similar to that of the enamel. And another study in Germany also looked at the one-year follow-up study, and they looked at this product, the characteristics of this product, to see what happens at the end of 1 year. So they were able to say that the color and light characteristics were pretty stable at the end of 1 year. So they recommended this technique as a possible method to improve aesthetics. And another study, again, that I was involved with is Andrew Leland, another resident at University of Texas. He looked at the staining properties of these lesions. So what he did, he had a bunch of teeth that had white spot lesions that were, these lesions were created in the lab. Then he applied this resin to these products, to this teeth, and then he subjected different groups to various of staining products like wine and coffee, orange juice, and he wanted to see what happens to this resin once you have these staining media in the mouth. So what he noticed and reported that, yes, indeed, the resin was getting stained quite easily. However, if you did prophylaxis, then just polishing was able to reverse the staining and bring the surface finish to its original. So those were the results of his study. Then in 2016, we have a systematic review on the management of post-orthodontic white spot lesions. And according to this group, there is a lack of reliable evidence to support enamel remineralization or camouflaging strategies to manage lesions. So it looks like we're back to square one. Maybe it's better just to prevent these lesions from the beginning. So I can imagine you are like, okay, what did we learn from this lecture? I'm confused. What am I going to use for my patient? So in 2013, American Dental Association came up with these clinical guidelines for the use of fluoride delivery systems. And this was for the general population, but I think we can apply that to our patient population because the middle row is for patients 6 to 18 years old, and the majority of our patients are children and teenagers. So evidence is in favor that the use of 2.26% fluoride varnish at least every 3 to 6 months is in favor for minimizing the lesions. Similarly, 1.23% fluoride gel for 4 minutes, at least 3 to 6 months also is in favor. And these are, of course, professionally applied topical fluoride agents. As far as home use, 0.09% fluoride monitorings, at least weekly, has some evidence that is in favor of use, and evidence favors the use of this treatment modality. Then later on in 2018, American Dental Association again came with another clinical practice guideline on non-restorative treatments for carious lesions, and this was a report. And based on report to arrest or reverse non-cavitated lesions on the facial and lingual surfaces, the report and the evidence recommended 1.23% APF gel application every 3 to 6 months, 5% sodium fluoride varnish every 3 to 6 months. And they concluded that although CPP-ACP may increase the chance of arrest or reversal by 3%, the results were not statistically or clinically significant. So I think, once again, CPP has some potential, and obviously it had 3% effect, but that wasn't clinically and statistically significant. So I think, as a summary, based on what we know right now, the very best thing that we can do is to choose our patients wisely. If our patients are already at risk because they have poor oral hygiene, we should put them in a vigorous oral hygiene regimen so that these patients can show us they can brush and they can take good care of their teeth, then start their orthodontic treatment. We can also band bands with resin modified glass ionomer cement, and maybe even bond brackets with resin modified glass ionomer cement. However, the evidence did not show any significant improvement, but if we want to do something to make us feel better, maybe we can do that. But definitely multiple application of fluoride in the form of gel, varnish, or sealant, ideally every 3 months, should be done throughout the orthodontic treatment. And post-treatment, I think once we have those patients at debond, let them gain their pre-orthodontic oral hygiene status by letting them brush with regular over-the-counter low concentration toothpaste if there are some lesions which are shallow, which have some maybe remineralization potential. And then after that, if we still want to improve the aesthetics, we can do microabrasion. And finally, maybe application of APF gel and sodium fluoride varnish. And resin infiltration, once again, is a pretty new product and it deceives the eye, so maybe something that we can use as a last resource. So with that, this is the end of my presentation. I know we're all going through difficult times because of the pandemic, and it was so nice to be, even though virtual, to be connected with you all. But Maya Angelou is one of my favorite authors, was one of my favorite authors, and still is. She passed away a few years ago. She said that I've learned that no matter what happens or how bad it seems today, life does go on and it will be better tomorrow. So I hope you stay safe and healthy. And I certainly hope that the country I always wanted to go, I will be able to go visit India soon. Thank you so much for having me. This was such a great honor. So thank you.
Thank you very much, ma'am. On behalf of IOS, I thank Dr. Escer Tufekci for enlightening us on diagnosis and management of white spot lesions in orthodontics and spending a valuable time with us joining the Ortho Illuminati International Webinar Series. I once again thank you, ma'am, for sharing a comprehensive, well-documented brainstorming session for IOS. Now I call our Honorary Secretary, Dr. Sridevi Badmanabhan, to share a few words and give the E-certificate as token of appreciation to Dr. Escer Tufekci.
Thank you very much. This is very nice. Thank you.
Thank you, Professor Escer Tufekci. That was wonderful. You know, we were concerned that people might consider this a purely research topic, but white spot lesions really is so important for clinicians also, because it's not just important to start orthodontic practice, orthodontic case, but it's also important to finish well. And you have showcased all the evidence and all the research so beautifully. And I hope you have more time, because we have a lot of participants today in spite of this being a holiday. And I can see a lot of questions in the Q&A section. So I hope you're going to be here for some more time and answer all those questions. But on behalf of the President, the office bearers, and all the members of the Indian Orthodontic Society, it's my pleasure to present you this certificate of appreciation. And we will also be emailing it to you.
Okay, once again, thank you so much, Professor.
Thank you.
It's been wonderful.
This was wonderful.
Very good.
All the esteemed panelists, Karvinda sir, Pradeep Raghav, Whittington, Gyana did a wonderful job with the presentation. Divya Roop, Dr. Sanjay, as usual, you were the rock star of the show, anchoring. And
Sanjay
all the attendees who have been patient enough and who waited through the entire almost 2 hours that we had the program. Thank you one and all. And once again, we'll conclude this meeting and wishing you all a safe time.
Thank you for such a well organized. I am really impressed. So thank you very much for making me a part of this.
Looking forward.
Stay safe and healthy. Until next time. Goodbye.
Bye-bye. Bye-bye.
Until next time. Bye-bye.
Yes.